Makeup! It's record. Oh.
Makeup.
Okay, you are on.
Oh, we're on. Okay, so basically there's a 5-step protocol for Dr. Asher's technique, which begins by loosening the muscles that start at the base of the skull, the upper trapezius muscle, levator scapula muscle, and the rhomboids major and minor. These are the muscles that would elevate the shoulder up towards the ear. And oftentimes if there's pain at the shoulder or limitation of the range between the humeral bone and the scapula bone, you're going to find that the shoulder, if somebody would try to raise it overhead, would hike. So a shoulder hike pattern. And the lotion that you would use is very important as well. Biotone is my favorite. I've experimented and used various types over the years. I haven't used anything but this since probably 10 years ago now. It's you can probably go to a massage therapy store. I can order you something through a catalog. The beauty of it is it's slippery, slippery, slippery. It stays slippery as long as you like. It doesn't soak into the skin, and it allows a nice gliding contact. It also doesn't have a lot of smell. It's never irritated somebody's skin. Some people are sensitive to lotions, either due to allergy, and you form a very deep red rash, and that's not something that most people want, so.
I don't.
Yeah. Exactly. In manual therapy, you would always proceed with a little bit of pressure, working your way through and feeling lumps and bumps and trigger points. Mainly you would be searching for the lumps and bumps that cause a reaction. In this case, the reaction would maybe be the hiking pattern. So something that reproduces the pattern that you see when somebody tries to use the arm itself or use the shoulder. You can use your fingers. Fingers tire quickly on most people. They won't on me. I can do this all day, but most people who don't use your hands every day doing manual therapy will fatigue quickly, and your hands will become achy and painful, so thereby employing the arm. The ulnar bone of the arm is a beautiful, long, straight bone, and if you start up by the base of the skull and you work your way out, you can use it almost like an iron to iron out all those muscles that cascade from the base of the skull by the occiput and down here out towards the shoulder blade. So you might want to pause it so that we don't use up too much tape, because I'm not going to change what I'm doing for a few minutes.
Action.
So we've spent some time here working on the muscles of the upper trapezius, levator scapula, and the rhomboids major and minor. And we can be using a thumb contact, a web contact, or a forearm contact. They're all nice. The forearm tends to be the easiest if you're not doing this every day and you're tiring. It's a nice way. And the seated position like this is nice because I can get my body weight on top of it.
And I noticed you put her arm back.
Yeah, and then exactly, and that's what I was going to talk about next, is
sorry.
that the position of the arm. I can get a little more of the weight of her arm pulling down for me here if I let it back by here, as opposed to it resting here up on the lap, which would elevate the shoulder slightly. The next thing we're going to do is we're going to work the lateral arm, okay? So, Liz, I'm going to have you lie down here on your side. And the emphasis is going to be placed here on trigger points and tenderness found in the anterior shoulder, the biceps tendon. You take a little lotion and you work the lotion over the skin of the area that you're going to be treating. And in this, I'm just spreading the lotion. I'm not doing a massage yet, just in case it looks like that. I'm just really getting this slippery. The strokes here in Dr. Asher's protocol are always done from the elbow up towards the shoulder. And we're going to be pausing in locations that some describe as pebbles, Some describe as sort of cables or ropey positions and places. So again, I might get my forearm. Now, another distinction here is that fingers are small, and when you run your fingers up, even if they're bunched together like this to create a broad surface, they don't quite cover as much surface area as a broader forearm. And therapeutically, they're really different, as you can probably feel. I can gather a lot of tissue using my forearm that I couldn't using my thumb. It's too small a surface area. Therapeutically, this is something that I've learned from Dr. Asher. I would have treated this more with my fingertips, only based on the fact that I would have thought my fingertips were more sensitive and I could get more feedback as far as the tissue sensitivity. You can look at somebody's eyes. It gives you a lot. When somebody's wincing, you know you're hurting them. If they're wincing so much, you can pause. So let's do one of the strips here. And you can bring the arm up. There's a feel under my forearm that I feel tissue almost like it's gathering, like I'm grabbing sheets on a bed. And I'm pushing those sheets along and they're starting to bunch up. So the resistance of those sheets against the mattress are starting to gain, and I can't, like right now, I'm blocked right now up against a barrier, a fascial barrier of the OEM, or a series of fascial network that comes down from the acromial cap and coalesces into where the deltoid muscle attaches here to the humerus. And I block it. I can also drift my forearm slightly towards the front of the arm, the anterior portion. That's where that biceps tendon is. And I've hit that barrier and I'm stuck against it right now. And back away and move. And I'm literally, in a sense, right on there. And I can look at the eyes. As soon as I find where I feel like I've got something that might be so much for Liz that she can't handle it, I don't want to continue to beat her up. That's just going to bruise. And it might even actually encourage the whole hiking pattern, the whole thing to get worse. So essentially you're trying to release tension when you're doing these things. Another element of Dr. Asher's protocol, which I think I've learned something from, is to hold releases longer. Sometimes upwards of 3 or 5 minutes. Once I do a pass would be where I'm starting from the lower arm, I'm working my way up the arm. I might stop a few times at places that I feel both tension and that build-up effect of the fascia. And that, of course, you can see that Liz reacts to these things. Again, I'm pressing down enough to get a reaction, but I'm not going to sit there and beat up the reaction. I'm going to back away when I find that spot. And I'm going to hold. Some of the nuance to this would be taking the hand over here by the wrist, laxing and tensing, laxing and tensing. And this way, I've tried to explore methods that would get me a release faster. I could sit here and I could press on a trigger point and I could wait to that trigger point by asking the patient, is this killing you? Yes, it's killing me. Okay, tell me when it's not killing you. And I would wait a few minutes. But what if I could do something to make that not killing me phase achieve that faster? Then we could utilize that. Around here, I feel like I have to come forward a little bit more. If the spot that I am trying to treat feels smaller, I can back away from using the broad contact of my arm and come back to more of a contact of the side of my finger. Then notice I'm not rushing through anything. We're not doing anything that would be done quickly or jarring to upset the nervous system or to make the shoulder. The last thing in the world we want is to do anything that makes that shoulder grab. Since, as most people will describe, it's oftentimes the most painful episodes of frozen shoulder are when I go to reach for something quickly and forget I have a frozen shoulder. Mm-hmm. So Hence that neurological concept of guarding pattern being kicked off by pain. The pain, well, we could speculate as to the pain being adhesions in the capsule, to a biceps tendon, to an inflammatory pattern, but something is going on that if the individual moves their arm too quickly, a very jolting neurological pain is ensued, and usually a guarding, which would be the muscles firing in the shoulder, rapidly moving up towards the ear. That's why we started with that upper trapezius pattern, because that tends to be the reaction that people have had over time of having any pain in the shoulder when they try to use it.
No, I've seen her wince like that when she's reached up to grab something and forget, or by reaction.
Then after you do these strips, and we might go 3 to 5 to 10 different patterns of stripping. Nice and relaxed till is. And I see that arm did not want to bend, so it was guarded a little bit. So I take it out, and then I can do some small shoulder mobilizations. In this, again, a lot of feel. I can get some rotational motions going. Without internally and externally rotating the arm, I'm going to simply do some circumduction patterns. These are cone-shaped patterns that the shoulder has available to it. This is called circumduction. And in circumduction, what I'm trying to feel is for how big a cone of resistance-free motion do I have available to me. And I make a little note in my mind's eye each time somebody comes in about whereabouts I got in the end of that session prior to this. So, and I just want to, and also with my left hand, I palpate the joint line, because there's good motion and there's sloppy motion. I could probably get Liz's arm to circumduct in a much wider cone, but what I would be doing is I'd be getting the whole shoulder blade and the humeral bone moving, and that's not what I want. What I want is I want motion of the humeral bone in the glenoid fossa, which is the small bony area that the humeral head sits in. And that means I want motion right here, so I palpate that articulation of the humeral head in that glenoid right in here, and then I feel that shoulder blade, and I make sure that shoulder blade is not moving and miming the motion of the humeral bone, because I want those two to separate. And one of the big dilemmas with frozen shoulder is that lack of separation. So if I go to raise my arm over my head, and the muscles in here are closed in, then the whole thing moves as a unit, as you see Liz doing. We want the openness. So one of the angles that I make a mark of when I first start treating the patient is what they call a scapular angle. You can measure this with a goniometer, but I eyeball it. And 90 degrees is usually where people will be limited, and I believe with Liz we started at 70 degrees. Let's see where she is today. We're at 70 degrees of the internal angle. That's not good. That doesn't bode well, because many patients, they will usually arrive here with somewhere around 90. So in staging this condition and staging the severity of Liz's compared to others, I've come to know this angle as being a very telling angle as far as the severity goes. And what I'm seeing here, it's about 80 degrees. It's 10 degrees off of where I want 90. She's pulling back a little bit too, so it's obviously not something she's enjoying. So let me just, nice and loose, let it go. Now pull your arm down towards, yep, and drop. And do that again, and drop. This is something out of Dr. Bobminski's book here, which is just a contract-relax concept. The contract-relax is a concept that I started doing with this condition many years ago, because I felt like the primary problem was a muscle spindle apparatus, which is located inside the muscle tissue. Your muscle spindle and your Golgi tendon organ are two entities that lie in your muscles and your tendons, which are stretch receptors. So I thought to myself, it's interesting. I can't get that humeral bone and the scapula to separate. Perhaps it's the muscles that would draw them back in, that they didn't want to be stretched. For some reason, they have miscalculated what length was. So I started treating using that concept with a lot of success. And I would slowly, gradually relax by massage, but also contract, relax. Because then I figured, oh, if the muscle contracts, the muscle spindle and the Golgi tendon organ feel good because now the tissue is being shortened and they're okay with that. They're just not good with lengthening. And I could use the refractory period. And in sports medicine, we do this for stretching hamstrings, we do this for stretching quadriceps, we do this for stretching broader base muscles for athletes to increase range when their range is lacking for hurdles or whatever else they need to do. So I thought, let me apply that concept to frozen shoulder. And I would have people contract as I just had Liz do, and I'll show you that again. Oh, there's a little bit of a click, which I like. Clicks are good right now. That means something is moving. Now I want you to pull your arm down towards your hip and then relax. Boom, we have a refractory period. I take advantage of it. Do it again now. Push and drop. Let it go now. So I wait. Okay, so here's some nuance. You do not want to push the arm overhead. You want to wait till you feel a release. A release, what does that feel like? Well, it feels like the arm isn't fighting me. There's a lot of fight in this condition. As I try to get this arm to go up, it's doing nicely right now. I wait. I back away a little bit. Take a deep breath, Liz. Exhale. Drop the tension, if you will. And I wait. Now, how much can I get out of that? That moment in time where Liz feels like she can let it go. And I wait. There's a lot of waiting. There's a lot of patience required. This is not going to go away quickly. It'll go away on its own terms, but if we could assuage it a bit, that's what this is all about. We're not stretching something really, we're releasing tension that the shoulder is holding. Stretching means we're forcing, and the frozen shoulder cannot be forcefully opened. It needs to be released. So gently pull your arm back down towards your hip and relax. And I wait, and what I feel right now is a beautiful freedom right here where there's no tension whatsoever. And Liz is not fighting me at all. And of course, it's because the arm is down close to the side of the body. But if I search around, and what you really have to do is I'm doing a little bit of those mobs, the mobilizations that I showed you, the circumduction mobilizations. Nice and relaxed, nice and relaxed. And I constantly instruct the patient to continually try to relax through some of these barriers. The barriers are there. There's speculation as to what the barriers are, whether or not there are adhesions that are formed in the capsule between that humeral bone and that glenoid cavity. There is a capsule that surrounds this joint line. The inside of that capsule is a group of cells called synovial cells that produce fluid. So the inside of the intracapsular region is basically a fibrous balloon with cells that make fluid lining the inside of the fibrous balloon that produce the fluid. And there's a lot of resistance to internal and external rotation. Again, speculation as to why that is everything from tension in the muscles to a capsular shrinking and less intracapsular space to a sloughing away of the synovial lining inside, which may have been a bit misinterpreted as adhesions back when this was first characterized. Whatever it is, we look at the functional loss. What can the shoulder not do? This is what we're going to train it to do again. Slowly, gradually, hopefully releasing tension as we do this. Feeling with my left hand that the motion is actually happening at the humeral glenoid articulation. That, again, can't be stated enough. You're not trying to free, the whole shoulder. You're freeing one articulation, which is this one. The next is you're going to free the articulation of the shoulder blade on the rib cage. That's kind of where we started with that upper trapezius and that rhomboid. The rhomboids, again, would limit the shoulder blades' motion to turn open in this direction. So I want to basically treat 3 different regions here. I want to treat the muscles that go from the base of the skull to the shoulder blade. Then I want to treat the muscles that go from the shoulder blade to the arm as the 2 major regions. And then I want to treat the lateral arm pattern as it comes up in the OEM fascial sheath that comes from that acromial bone down into the deltoid insertion. And I can really kind of mix and match all 3 of those here based on, really on, again, feel. If I feel like something I'm doing is working and suddenly Liz can open up her arm a little bit, I'm going to continue to do that until I've exhausted that particular avenue. And I'll hold. And maybe sometimes I'll do contract relax at the end range like we are right now. Gently squeeze down, Liz. Yeah, nice. Keep going. And drop. And when I say nice, is I feel a motion at the glenohumeral joint. That's the big one. When I feel motion at the glenohumeral, I know I'm really opening up the core of the problem and not just some superficial reaction to the core of the problem. You want to get to the core. And the core in this case is certainly deep in the joint line. That you can feel. There's, yeah. Now in the back, let's do the 3rd phase of this, of Dr. Asher's protocol now. So we've done, again, after we do the lateral arm work, coming up from the elbow towards the shoulder, we go through our circumduction. The circumduction mobilizations can include some slight internal external rotation. That's very rigid on Liz. Very little freedom there. And I look to see if I can find something around the joint line to provide me some further relief. Exactly. Now let's do the posterior capsule. The next phase is going to be a release. Now, in Dr. Asher's protocol, we have a posterior capsule issue. The posterior capsule back here. The capsule, again, is the capsule that surrounds the humeral head and its attachment to the glenoid fossa. And I can come in. The shoulder blade on Liz ends right where my finger is. It's a triangular shaped structure here. And some of the muscles to mention here are the teres major, teres minor, and subscapularis muscle. They are the subscapularis being under. I can't touch it in this position. I'll show you how to do that later. But I can touch the infraspinatus muscle. The infraspinatus muscle is the easiest of the muscles to access because it's the one right here. It's very easy to access. Now notice Liz doesn't like her arm in that position. So, and also notice the tremendous amount of bend at the elbow. Most patients without frozen shoulder can have their arm straight and straight down like this with no problem at all. That's the goal of the therapy, is to get it there. But it doesn't like it. So as I try to have Liz let her arm fall, the arm wants to bend because it relieves tension. So we can make some mental notes, again, like I said earlier about other ranges of motion, we can make some mental notes as to where Liz's arm is and how much bend is at the elbow. One of the things I find as a frozen shoulder starts to heal and free is that not only is this arm falling down, but it's falling down with a straight elbow. So I know now that there's total freedom and there's no guarding pattern, there's no withdrawal pattern. The shoulder wanting to withdraw back towards itself is something that you see in everybody with frozen shoulder. First, I'm going to take some of that massage lotion again. I'm going to just prep the area. I'm not really treating it so much yet, as I'm just getting the lotion so I can have a slippery interface between my fingers, elbow, and Liz's shoulder. I feel for tender points, and again, this just comes with a lot of experience, knowing when a lump is something you treat or a lump is just a muscle. In this region here, I happen to know the anatomy very well, and so what I'm looking at is here is the superior border of the scapula. Here's the medial border of the scapula, here's the inferior angle of the scapula, and I know that right underneath here is the edge of the scapula, or the lateral border. And I happen to know that the teres major and teres minor muscles originate down here. They're very much a problem in this condition. And the teres major muscle is going to start here, and it's going to dive deep under the armpit, and it's actually going to attach underneath because it's an internal rotator. So it attaches underside, and when it contracts, the humeral bone turns inward as an internal rotator. The teres minor, which really originates just above it, right about here, actually comes to the lateral side, or the outside of the humeral bone, and it turns it out, along with the infraspinatus. So we can do some infraspinatus stripping and teres minor stripping, starting from the origin of those muscles, working out towards their insertion, which is where they attach to the humeral bone. I can strip in various directions, down, up, across, all of them based on feel, based on what I feel if I'm achieving a result, which is to allow, and I like what I'm seeing, well, there's a better angle across, there's a little less bend at the elbow right now, and I'm going to apply a posterior capsule release. This is, again, anatomically the posterior capsule, the back. Posterior means behind. Here is the spine of the scapula. Here's the infraspinatus, and if I follow that infraspinatus underneath the spine of the scapula, I know, yeah, and you can see the eyes. And I find it with my thumb. So as a reference point, there's a little bit of a sunspot right there. Sorry, Liz. And I'm going to get my elbow. Now, raise the elbow up towards the ceiling slightly.
Right.
Your right elbow, yeah. And drop. Raise the elbow up slightly and drop. So I'm not having her really raise the arm, I'm having her initiate raising the arm. I've just found that's, again, something that I've kind of discovered myself in treating various other types of injuries, not so much frozen shoulder, but when you're doing a release, okay, part of the release is happening in the muscle fascia. And I can see her wriggling about, so I may have to back away. I do. And this is the nuance. You cannot sit there and let somebody start to writhe in pain and get anywhere. I may even cause it to get worse if I do that. So here we go back, and again, each of the phases of the manual therapy, the strips and releases that you do is going to be followed by some circumduction motions, mobilizations. They feel good. They let the patient get a little breather. They let you get a breather. And they also let me reestablish whether or not I'm actually getting something to happen inside. Another concept that's important is scapulohumeral rhythm and inferior translation of the humeral head. This is a major portion of frozen shoulder and its ability to limit range. And I believe actually maybe one of the theoretical tenets that is most important in what a frozen shoulder really is. My humeral bone, to go over my head, sweeps 180 degrees. My scapula must sweep 60 degrees. So for every 3 degrees, my humeral bone would sweep if I were to making a goniometric analysis of this and watching my sweep of my humeral bone. My shoulder blade behind me must be moving 60 degrees along with it for full range to be achieved. Another portion of that is what they call inferior translation. And I'm going to pause for a moment on you, Liz, just to show you. Here's that glenoid cavity, and here's my humeral bone inside. In Liz, as she goes to raise her arm up, not only is there a lock between these two bones, but when we get to 90 degrees, a key transition takes place. The rotator cuff muscles, from 0 to 90 degrees, actually pull the humeral head into the joint line, so into the glenoid fossa. But at 90 degrees, they must actually serve, because of the angles that these muscles pull and their function, they begin to be what they call inferior translators. Inferior translation is if I have a round object in a round cup, it will continue to rise up the cup unless it glides down. So to maintain the position of my humeral head, I must glide down while I roll up. This is true of all rounded joints that have a hinge type of a system. But it's particularly difficult in the shoulder joint because the humeral bone only attaches to our entire body from the shoulder blade, and the shoulder blade only attaches to the body at the sternoclavicular joint over here. You got a swing arm clavicle, and you have a shoulder blade that moves. It has to move around, so this articulation here must move together, and at 90 degrees, the muscles that pull it down are the rotator cuff muscles with all that tenderness. It was my thought years ago that it was the weakness of those muscles due to pain that disallowed them firing strong enough to cause inferior translation. So all that crazy stuff being said, I get my arm back. So what I thought to myself was, let me do an assisted. In rehabilitation, we have a passive phase of rehabilitation, and we have an active assist phase of rehabilitation, then we have an active phase. We go from passive. Passive is all the stuff I'm doing right now. Listen and just lie here and enjoy that I'm doing everything for her. The active assist portion of this would be me doing it, actually. It's still passive therapeutically, but I'm going to do what those rotator cuff muscles should be doing, which is to draw that humeral head downward as we approach 90 degrees. So I thought to myself, let me do all of the motion passively for her until I can retrain that humeral head to get down there, and then we can go to the gym and start doing some exercises that turn these muscles back on. This is not easily achieved because there's pain and there's tightness until I can get past 90 degrees, a key barrier in treating this condition. From 0 to 90 is usually achievable pretty quickly and easily. So we want pain reduction so that we don't set off this cascade of guarding. And then we want to start encouraging range of motion, which returns function, in that order. And I'm feel the humeral head, I'm right on it. The acromial bone to get some guard marks is the big one you feel. Very easy to feel the acromial process of your shoulder blade. In Liz, it's right here. My finger's on the back portion here. If I come across, there's the front portion here. If I slip just laterally, I fall off the edge of that acromial bone and I feel the humeral bone. It's that humeral head that I push downward, and I do it with a fairly broad as I lift the arm upward. So again, I'm actually manually doing this to the humeral head. And then my fingertips would be the acromial bone, which this goes and bumps into. And the structures that lie between that acromium and that humeral head are very, very susceptible to injury. Those would be the tendons of the rotator cuff, the capsule itself, and two main bursal sacs, which would be the subacromial bursa and the subdeltoid bursa. The bursal sacs, where this was often called bursitis many years ago. Totally different. Bursitis could ensue it. Anything painful could kick off a guarding reaction. But the pain, I've treated many patients with bursitis. The pain pattern is usually a dull, achy pain. Sometimes it rests, but range of motion is generally not lost all that much. So this seems to be perhaps a normal subacromial impingement type of a condition run amok. It's the freezing of the shoulder that differentiates it from a standard shoulder injury, which would be a patient coming in after playing 5 sets of tennis, or maybe working in the garden too aggressively, something that has hurt the shoulder, but not created a freezing pattern like we're seeing. Coming around the front are a couple of muscles to note as well. One of them, a major contributor perhaps to the lack of range found in frozen shoulder, is not the pec major muscle, and that could be part of it, or the latissimus dorsi muscle, which I haven't mentioned, which is a muscle that starts actually down here by your hip, comes out of a fascial sheath, and connects underneath the shoulder blade to the humeral bone. These are both internal rotators of the humeral bone. They're very large, they're very strong, and they can often overwhelm the smaller rotator cuff muscles. So they internal rotators of the rotator cuff are very difficult to diagnose because they are overwhelmed by larger ones. But another one is pec minor. The reason why the pec minor is such a key player, and this one could be, is the fact that it starts on the rib cage right here below the pec major. I'm probably touching about the origin of that muscle right now. And it's got a fairly broad origin, and it coalesces to a small point and attaches to the coracoid process. The coracoid process is literally a bony projection. The scapular bone is a very oddly shaped bone. It's triangular in the back. It has a fairly large, broad, bony mass at the top, the acromion. And then you've got this funky little offshoot coming out front called the coracoid process, which is the origin of a couple of your biceps muscles, but also the attachment of the pec minor. And it can take the shoulder blade and it can pull it down and in if it's shortened and tight. So I like to go into that, find if there's some trigger points found in that muscle, that pec minor. And right there I find one. And again, I can mix and match some of the concepts that I've already discussed, which would be circumduction mobilization, trigger point releases. In this case, I can bring the arm backward in the joint line. Treat that anterior shoulder portion where that biceps tendon comes in. The biceps tendon of the biceps muscle does not attach to the coracoid process. One of the medial biceps muscles does. The Coracobrachialis, hence its name, the coracoid process, or the Coracobrachialis. That muscle does originate on the coracoid and comes down more of the medial portion and attaches to the humeral bone, whereas the major biceps muscle, the biceps brachii, forms from a very tortuous little tendon here. The biceps tendon is angulated, like my finger is, into the capsule. It makes sort of a 90-degree turn, passes under the transverse ligament, and then the biceps muscle begins, attaches all the way down here. So again, we're trying to release tension in any of these muscles around the shoulder joint so that we can enjoy a more open freedom of motion. And again, I'm just going to take and do, these are more just classic joint mobilizations or glenohumeral joint. I get my hands right up close to the joint line. And I'm encouraging motion right there at that glenohumeral. I'm doing mini circumduction motions in various planes and various positions, both rotational, extension, flexion, and abduction. What I have found with a lot of practitioners is this inability not just to know the anatomy very well, but to have, I think, the strength and the endurance to be able to do this for an hour and a half straight, because that's what it requires. I think that ultimately any of the success I have had may be in large part predicated on the fact that I'm strong and I have endurance and I can focus for a long period of time, and that's required. All three of those are required to cure this condition. And maybe perhaps why standard medicine doesn't believe there is a cure for this condition other than surgical releases of the capsule, cortisone injections for inflammation, and time for it to go through its phases. There's a lot of, yeah. Let's take a break for just a moment there.
Yeah, it's just like worry.
I can do this. Now, I'm stretching the nerves. How come I'm not making it worse?
Yeah.
So if the nerve's entrapped, how come it's not making this worse? It would be. It does in the sciatic nerve in a dural tension test. It doesn't in this. We're just picking up on here, we're talking about nerve entrapments a little bit and why there is such a interesting set of findings in Liz and many others with frozen shoulder down the arm. Why do patients with adhesions here, even at sleep at night, have pain down in here? So one of the things that I've explored over the years is, again, digressing a bit from what I thought were myofascial releases or trigger point releases, would be more where the nerves attached to the muscles, in this case will be the radial nerve coming around the back of the humeral epicondyle here. I've used this technique very successfully in treating people with tennis elbow that really aren't lateral epicondylitis. They are radial nerve entrapments into the forearm muscles here, right where the radial nerve comes and dives deep to feed the extensor group of muscles. And she has particular sensitivity along the ulnar nerve. And of course, Dr. Asher's thoughts on the biceps tendon being the major issue, I thought perhaps may have been more of a median nerve issue. So sensitivity to the three main nerves that run down the arm has always been a fascinating portion of this condition. In exploring that, I've used tests that I've found effective in treating other nerve entrapments, particularly the sciatic nerve entrapments, and using a straight leg raise exam. The doctors that might be listening to this will understand this, and that you do a straight leg raise exam on a patient, and very rarely do you find it to be a true radicular pain pattern or sharpshooting pain going down to some distribution in the foot or the leg, but more you find people that say, well, sometimes it hurts in my hip or my back, and so I would back away and I could do a Bragard's examination, which would test the nerve and not just the hamstring that's feeling tight. And I've tried that same set of tests and derived them for testing the radial nerve in this case. And notice that Liz's pain is not increased by stretching that nerve through its channels. So the nerve entrapment or the cord theory here has lessened on my hierarchy of what might be going on with frozen shoulder, since clearly we still do not know. But it's still compelling, and compelling because whenever you treat somebody with frozen shoulder and they're complaining about pain radiating all the way down the forearm, I've had a few people from the... So for the completion of today, I'm going to perform a protocol or a position that I originally found to be intriguing with frozen shoulders, and actually we were just talking about how poor camera people we were, and right now I'm going to continue to talk while Lori proves my point. None of us should be in Hollywood.
I'm gonna power on.
Sure, it's back.
It is back.
And shoulder is in the frame.
Yeah.
Good. All right, so sort of as an aside, really quick from frozen shoulder itself, I had many patients over the years that were sent to me and told they had an impingement syndrome. This is a broad-based category of a shoulder that hurts when somebody raises it overhead. And I'll never forget the day that I not that I was doubting things were impinged, but like a lot of discovery, there's serendipity. And the serendipitous, or that little moment in time, was I would take a patient's arm and place it over the head. We can't do that with Liz here. And they would tell me they feel a lot of pain in the top of the shoulder. So from my physical therapy training, I would immediately draw the conclusion that there was a subacromial impingement. And I would treat it using ultrasound and E-stim and ice and time and rest, maybe moving into therapeutic exercises when the pain would go away. And one day, I just decided I'm going to compress into the teres major and minor. We go back to that. And all of a sudden they would say, the pain's gone. I don't feel pain anymore in the top of my shoulder. So not everything that hurts, whoever's watching this tape above the top here, is coming from the top. Simply stated. Referral patterns from the infraspinatus, teres major and minor, maybe even from the subscapularis down in here, oftentimes can be referring pain to their insertion points under that acromial bone and around the capsule of the joint line. But back to where the first few patients that I treated with frozen shoulder, and I didn't even know what frozen shoulder was at that point, I again noticed this closed angle. We mentioned that Liz's was 70, and at the moment it's sitting at about, again, if I really want to be critical, we're about 80 degrees. I need another 10 to get to 90 here. This would be a 90 point. We're closed in at 80. Sorry. And you notice just the slightest. So I take my leg, and I'm using it as a little bit of an assistant here. I can lift the humeral bone up. This is a very nice position for the practitioner as well. It sets the shoulder up in a position where I can see it, I can see angles, I can see hiking patterns, and I can see where it wants to go, and I'm able to use my leg as an assistant and the table as an assistant for myself. Yeah, and that's why I like this position, because I can back away, let Liz's arm come back in, and I feel it right in here. So, lateral border of the scapula, inferior angle, my thumb, acromion, draw a line, that's my lateral border of the scapula underneath these muscles. So I know to the left of this is the infraspinatus, and to the right of this is teres major and minor. Then I can just come down to that inferior border of the scapula, and you can see, if I touch that, do you see that hiking pattern? That's a hiking pattern. That's a withdrawal pattern. The shoulder's withdrawing from what I'm doing. So I back away and I reestablish proper position. I don't want to do anything that makes that shoulder go up towards the ear, because I'm just encouraging a nasty hiking pattern. And she can almost not even stand this position. So I'm going to back away a little bit. Is that better, Liz?
A little bit.
Okay, so I'm going to raise this up. I'll show you why in just a second. Nice and loose. I'm going to hold it, and I'm going to wait. I can trap her forearm. Is that better?
Yeah.
Okay, so now I'm providing some support, because literally at this stage of Liz's condition, the weight of her arm is enough to just want to withdraw. I must find comfortable positions where she can completely relax. Then we can go back in and we can start to elicit pain again. I can also use my legs. If I squeeze her arm in between my legs, I can do a little bit of a distraction downward here, a reposition, and again, just getting some more help using my legs to treat. I can use thumbs. I can feel that lateral border of the scapula, and I can strip. Now let the weight of your arm get very heavy. Lots of communication, if I haven't said that, and I don't think I have. Much of therapy in general is communication, constant communication. How is that? Are you okay? You can do a lot of it with your fingers, an intuition in looking at eyes, but when somebody's face down the table, your eyes are now taken out of the equation. And I've got to go on feel. And the feel is when I touch something and I feel the guard, I know I'm on something. Plus, I know the normal anatomy, I know how it should feel. There should be a certain suppleness to the musculature. It shouldn't feel ropey. It shouldn't feel rigid, and it does here. This feels very rigid. And I can get in my arm in the broader base again, contact, like we did earlier on the lateral arm. Number one, it can save my hands if they start to tire. And therapeutically speaking, I think I can use a broader contact, which does have a different therapeutic outcome than fingers do. The broad contacts tend to build up more pain. They build up more tissue underneath what you're stripping through. And I would say I used to think it was a bit of a cop-out to use my arms and my elbows because I thought it was people that didn't want to use their hands, but I've actually learned to embrace some of these things, and not just a cop-out, but it has a different therapeutic outcome, and sometimes better than the fingers. That's also really effective up here. When I'm treating a larger area like a low back. Is that okay, Liz?
Yep.
Your arm can dangle there comfortably?
Yeah. Oh.
So, the medial border of the scapula is just outside of my elbow. I'm taking, again, the rhomboids, major and minor, middle trapezius. And even if the latissimus muscle comes up out of its fascial sheath down here and starts to dive underneath the shoulder blade. But mostly it's rhomboid, major, minor, and middle trap.
Oh, oh.
I'll back away, but I don't want to leave it.
That feels like a bone.
That's not. That's muscle.
Ugh.
Bone is there.
Oh.
Wow. So we've got something here. Because I'm not pushing very hard at all right now. In fact, I've backed away where literally it's just the passive weight of my arm with no pressure down. So, do I want to leave that? Definitely not. But, do I have to deviate from what I was doing? Certainly yes, because doing something that's killing Liz is not getting me anywhere with this. I have to back away, and I'm going to do a series of strips, like we did with the lateral arm and the anterior arm, and I might even do a hold.
So your pressure is on or toward your elbow, correct? Not on your forearm?
It's a little bit of both, but more towards my elbow, yeah. I'm using that olecranon process of my elbow here. That's it, Liz. Drop the weight of the arm, please. Yep. Let it dangle over the edge of this table. Let it dangle. Sometimes I'll take the tissue from the spine and I'll drag it out over the top by the upper trap and levator, like we started with today in that seated position. There's another nice position to work on that. And what I usually find with the stripping procedure is obviously each pass becomes less and less tender. We're not there yet, but it will be. One of the other positions in as far as both evaluation and outcomes, which we need. We always need outcomes. We have to know we're making progress. So we evaluate what I call Appleys 3 position. The Appleys 3 position is the Appleys examination for shoulders, and I call it the third position because it's usually the third one that we learned, where the thumb would have to come up the back. And Liz can't do this yet, but that would look like this. That's what we want Liz's arm to be able to do. Can't do it. And that is obviously, that's a combination of extension, adduction, and internal rotation. So there's 3 different ranges that are necessary within this articulation to make that particular position happen. And I've found over the years that that position is usually elicits the greatest amount of pain and the greatest amount of range of motion loss, whether it be a garden variety tennis injury or a frozen shoulder. The first position that of those 3 that I usually would work on would be extension. It's the one that's the easiest to achieve, and it gets us going. Then I'm going to work on adduction. The internal and external rotation components tend to be the most difficult. Let's work a little contract, relax. So Liz, push the arm down, please. And relax. Drop the tension, drop the tension, drop the tension. And push down. And drop. Now notice, I could get Liz's arm higher if I let the shoulder blade hike. See? But we don't want that. That's sloppy. That's ugly motion. We want that motion to happen here in that joint line, the GH joint, glenohumeral joint. Push the arm straight down, please, and drop. This is just, again, nice. And do that again, and drop. Gently push the arm straight down, and drop. And drop. No contractions now, no contractions, no contractions. Heavy arm. Take a deep breath. Let the arm and shoulder be very heavy. You can see how painstaking this is. This is where the patience and time. So those that have contacted me to find out whether or not they want to get involved in treating frozen shoulders, the first question I ask them is, how long do you allocate to a patient visit? If they tell me 5 to 10 minutes, I say you don't want to do this, because you're not going to do anything in 5 or 10 minutes. You can't even relax the patient's shoulder in 5 or 10 minutes to get going on this. So, you know, the practice model is an important variable here. You've got to have a practice like mine. I've kind of chosen this. I don't make as much money as many, but I find it rewarding to spend the time and fix something as challenging as this is to fix. All contributions to the Babinski Foundation are warmly accepted. You ever wonder how nonprofit organizations make money, Liz? It's like, nonprofit, how do they pay you? Just finishing up here, I think. We gotta probably have somebody waiting for me. Let me just check here. Hey, Liz, she's not here yet.
Oh, dear.
Yeah. You got a nasty one, I'll tell you.
I know.
Pink Floyd playing?
Coldplay. Has a bit of that, doesn't it? Has that ethereal sound. Yeah.
So I got a great birthday gift from Lori.
What's that?
An iPod with 50 songs, one from each year since I was born.
Oh, neat. That's a great idea.
Yeah.
You guys know Joe Jackson at all?
Mm-hmm.
Love him. been my favorite for 25 years, and he has a new album out called Rain.
Yeah, I heard it's pretty good.
It is. I was listening. The first track is Invisible Man, and I love it.
2 minutes. I'm counting. Yeah, I heard it was pretty good.
You know what he's doing is very interesting on his site. There's a link on it. It says smoking. I don't know what's smoking. I didn't even know Joe Jackson smoked, but apparently he likes to smoke cigarettes, and he doesn't like being told he can't do it in restaurants. So he has gone and he's doing research, and he's kind of refuting all of the both smoking and secondhand smoking as a cause of cancer. I mean, it's hard to imagine it. He could, but I think he feels, I've never, I mean, he's never really been cause oriented.
No.
But he's taken this one on. It's on his website.
You can tell when she moves her legs, can't you?
Yeah.
That spot right there where your thumb is.
I'll just hold that. Now,
What is that spot?
this would be, again, could be considered the posterior capsule. It also, more superficially, would be the teres major and the teres minor muscles as they start to go underneath the rear deltoid. You can shake that arm a little bit, Liz. Breathe through it. Tell me when all you feel is the pressure of my thumb and not the pain anymore.
Pain's gone.
Okay. Which is a fascinating part of treating trigger points. Are, initially you elicit this tremendous response, and if you hold them for sometimes upwards of just 2 to 10 seconds, all of a sudden people don't, the pain's all gone.
The myofascial therapist does a lot of that.
Yeah. Holds.
Yeah.
Less than a minute.
Now, squeeze your elbow down onto my leg. You got it, and drop. And drop. Now don't contract yet. Don't contract. Let it go, let it go, let it go, let it go. And squeeze and drop.
Oh.
Can you drop it? Can you drop it? I'll back away.
No. Oh.
Deep breath.